Okay, so welcome everyone to this special edition of our webinar series entitled Best of EASD. Today, several early careers in researchers from across Europe who attended the EASD annual meeting in 2023 will share their impressions and what they have learned during the conference. So first of all, we would like to the national associations who have connected us to nominate the speakers that we have today. And also we would like to thank the organizers of the annual meeting in Hamburg for the excellent scientific program and also the excellent organization of the event. I'm Beatriz Merino, Antolin from University of Valladolid, and my colleague Rula Bakar from the University of Cambridge, and we have the pleasure to moderate this special webinar as members of EASD Early Career Academy Committee. This afternoon, we will enjoy with the impression of 4 young researchers, women researchers, of the highlights of EASD annual meeting in Hamburg. Each of them will talk about a general topic related with their experience and interest in diabetes research. And the speakers will have 10 minutes or to present their impression, and afterwards we will open to discussion for 5 minutes, in which we encourage you to participate. You can raise your hand to intervene or leave us your questions in the chat. And now I give the way to Rula, who will introduce the first speaker of the session on the topic. And I hope you enjoy, and thank you very much for being here today with us.
Thank you, Bea, and hello, everyone. I'm delighted to introduce our first speaker for today, Katerina Kudilkova. Katerina is in the middle of her doctoral study in biomedicine, specifically focusing on human physiology and pathophysiology at the Third Faculty of Medicine, Charles University in the Czech Republic. Today, Katerina will talk about peripheral hormone action. Thank you, Katerina, for being with us, and the stage is yours. You can start.
Thank you very much for the introduction. I will just start my presentation. Can you see it now?
Yes, we can.
Perfect. So it was great to be in Hamburg, and we had many great presentations. So it was quite hard to select a few. But at the end, I chose 4 of them with one small bonus. And I will present you briefly the research that was done. So the first one was in the oral presentation section, incretins and glucagon in action. And it was about the glucagon resistance. It was presented by Dr. Supli from Denmark. And the idea behind this research was that some time ago, it was found that type 2 diabetic people have elevated glucagon levels. This, in studies that were done after that, was associated more with obesity and fatty liver disease. And the higher glucagon levels were also associated with higher amino acids. Also, doctor described briefly the liver alpha cell axis, which constitutes of feedback loop. When circulating amino acids stimulate glucagon secretion from pancreatic alpha cells, and glucagon in turn controls the metabolism of amino acids. So this is the normal feedback loop, but the hypothesis behind research was that in NAFLD patients, the liver became resistant to glucagon. So the turnover of amino acids in liver is decreased, which leads to increase of amino acids in the blood. And that increases glucagon levels and leads to hyperglucagonemia, which can also contribute to higher fasting glucose. So the aim of the study was to find out whether glucagon resistance can be induced in healthy individuals by steatosis promoting diet. So what they did, they had 20 lean male participants, and they feed them with hypercaloric diet for 2 weeks. And after that, 8 weeks of recovery period with normal regime followed. And they have done examination in each visit. So at baseline, after 2 weeks of the diet, and after 8 weeks of recovery. And in the exams, they did MRI scan to assess hepatic steatosis, and they also did pancreatic clamp. So how was it performed? They administered somatostatin at first to block endogenous production of pancreatic hormones. And then they administered insulin and glucagon at physiological levels to see the normal levels and the reaction. And after that, they increased glucagon. And by that they could assess metabolism in normal physiological glucagon levels and also in hyperglucagonemia. And the results of the study was that after 2 weeks of hypercaloric diet, the subjects gained weight. It was 1.8% of fat. And interesting was that liver fat increased by 382%. So that was enormous increase after 2 weeks of this diet. However, it was normalized after the recovery period. The other interesting thing was that parameters of glucose metabolism were normal in all the visits, but insulin and C-peptide levels were higher by 56% after the intervention. So at this graph on the right side, you can see the values of amino acids, which were assessed in all of the 3 limit visits. And you can see there that during the basal visits and after recovery, when you administer higher glucagon doses, the amino acids are actually decreasing. So that's like the normal state. However, after the after the diet, actually the amino acids are higher, and they are also staying higher after the administration of higher dose of glucagon. So the author concluded that there were some signs of glucagon resistance after 2 weeks of hypercaloric diet, and that this was reversible after 8 weeks of normal regime. So that was the first study I wanted to show you. And then we have the second study, which was in the same oral presentation group. And it was about the incretin effect, which is thing described by Professor Nauk in the 1990s. And briefly, it is the difference between oral and IV administration of glucose and the reaction of insulin. So, which is because of intestine hormones incretin. So what the authors did was that they have 12 young lean individuals. They administered them IV glucose to clamp glycemia at hyperglycemic state. And then they administered blockers of incretins, so blocker of GIP and blocker on GLP, either alone or together, or they have control with only saline. So this was like the first part of the study. And in the second part, they administered glucose to duodenum at the same rate for every occasion. And then they followed glucose levels, insulin levels, gut hormones, and also the levels of the administered blockers. And what we can see here is that when only saline was administered, the curve is actually quite flat. That's the C-peptide, so we can observe the insulin production by that. When they administered blockers, or when they administered only glucose and saline with no blocker, there was actually the highest response of C-peptide. When blockers were administered, the response in C-peptide was actually lower and lower. But the interesting part was that when both of the blockers were administered, the effect of incretin was actually reduced only by 70%. So there was still some residual effect. And after this presentation, there was quite a long discussion about what could be the effects of these findings. And the idea was that maybe the blockers were not high enough to block all of the incretin response, or that there could be some other incretin, like maybe CKK or PYY can have some effects, or glucagon. And also there was Professor Nauk himself, and he asked whether this could be due to high levels of glycemia, and maybe glucose could stimulate some insulin secretion in this study as well. So that was another quite interesting study that we could hear in Hamburg. Then I have a next one, which dealt with the glucose sensing in portal vein. Because glucose sensing is done at two main places in the body. It's either in hypothalamus, which focuses mostly on hypoglycemia, and in portal vein, which senses hyperglycemia. And the sensors, the signals from portal vein are processed through vagal nerve to CNS, and GLP-1 receptors are needed for these signals. So if we administered blockers of GLP-1, there is actually no signal in the vagus nerve. And what the professor observed was that GLP-1 levels density is decreased in insulin-resistant animals. So the question was whether it is possible to restore the glucose sensing properties in portal vein with substances that could probably increase the GLP-1 receptors in portal vein. So what they did, they had pigs actually for this study, and they induced insulin resistance by hypercaloric diet in these animals. And then they did MRI scans to visualize the density of GLP-1 receptors. After that, they inserted catheters and perfused with selected substances for 8 weeks. So selected substances that should increase the GLP-1 receptor density were metformin, exenatide, and dihydrotestosterone. And the results were that only with dihydrotestosterone there was some effect observed, and actually the GLP-1 receptor density was normalized after 8 weeks of perfusion of portal vein with this hormone. And also they did hyperinsulinemic euglycemic clamp before the intervention and after the intervention. And actually they could observe that insulin sensitivity was normalized after this intervention. What was interesting was that the GLP-1 receptor density increased only in the portal vein and not in other part of the animal body. And after that, there was some discussion whether this effect would be the same in females as in males, which in this study, there were 5 animals and 3 of them were males and 2 were females. So this effect was observed in all of them, but it's very small sample. And then there were some discussions about first pass effect of the dihydrotestosterone, and actually where is this hormone working in the cell and other stuff. So that was another quite interesting study. And the last one I selected was in the oral presentation, adipocytes, impact of obesity and metabolic health. And it was about leptin and leptin levels, which is actually hormone produced by adipose tissue, which regulate appetite. And in this study, they had hypothesis that people with the same fat percentage that have different leptin levels would have some different metabolic health. This study was based on the EG risk cohort, which was cohort based in Europe. It has around 1,500 participants, and they had OGTT test, hyperinsulinemic euglycemic clamp, lipidomic studies, and other examinations. And what the researchers in this study did were that they assessed fasting leptin levels. Then they divided the cohort by sex and by leptin levels, and also by BMI category. And what they could see was that the basal parameters were actually same for the whole group, but high leptin group had much higher insulin levels during OGTT. And also data from hyperinsulinemic clamp. In this study, the group with higher leptin had lower insulin sensitivity across the whole BMI spectrum. So basically the conclusion was that with the same adiposity, which you can see here, the groups with BMI, the different leptin levels were associated with different metabolic health. So, for instance, in the BMI group below 25, you can see that actually the higher leptin level group has actually the same insulin sensitivity as the BMI group that is actually between 25 and 30. So that was quite interesting study as well. It was only observatory, so there couldn't be any conclusions out of that. But after that, there was quite an interesting discussion that this could be based on different adipose tissue biology and function, and maybe that larger adipocytes could secrete more leptin and have also altered vascularization, and maybe there could be higher state of inflammation in some groups. So for other assessment, biopsies would definitely be needed to assess the properties of adipose tissue. Also, there was discussed the possibility of leptin resistance. And yeah, that was this study. And I realize I'm talking for too long. So the last bonus was the talk, which was actually in the section of EASD Lilly Centennial Anniversary Prize Lecture, and it was done by Professor Schumann. And it was about the role of ectopic lipid in insulin resistance and cardiometabolic disease. And I highly recommend this lecture because it was very interesting. And Professor Schumann presented his work, which was done over 3 decades, and it helped in understanding of pathogenesis of type 2 diabetes, especially the ectopic adipose tissue, ectopic adipose tissue and its properties and influence on insulin resistance and other stuff. So I used summary from his presentation, which states that overnutrition leads to ectopic lipid accumulation and causes insulin resistance, which is very brief, and I highly recommend his presentation. It was very nice. So by that, I'm at the end of my presentation. Thank you for your attention, and I'm ready to discuss any questions I would be able to answer.
Thank you, Katrina, for this insightful and clear presentations. If anyone would like to ask Katrina any question, please don't hesitate to unmute and speak up, or alternatively, you can put your question in the chat. So Katrina, if I may start with the first questions, and from the first oral presentation you presented, I was wondering whether the glucose resistant was associated with insulin resistance in that study.
You mean the glycagon resistance? Yeah.
What's with insulin resistance?
Actually, I don't have any information about that, because I think they only observed the metabolism of amino acids, and there was stated that that there were no change, I think, in the glucose, in the glucose metabolism. So I don't think that there was this comparison made, but it would definitely be interesting, and I would expect there to be some resistance as well if they were like
values of insulin and C-peptide were elevated. Okay.
And also at the bottom of the page you have the link to Virtual Congress when you can see all of these presentation.
Yeah. Does anyone have any other question? B, would you like to move to our second speaker?
So let's move on the second speaker. Our second speaker is Julia Sanchez-Feinos. She completed her PhD in 2021 in IMIBIC in Cordoba, in Spain. And her investigation was focused in novel mediators of adipose tissue and the development of obesity and metabolic diseases. Currently, Julia is a postdoc researcher in a molecular cardiology laboratory in the Karolinska Institute in Stockholm, Sweden, under the supervision of Professor Francesco Consentino. And there she's focusing the epigenetic mechanisms that underlie vascular and cardiac dysfunction in obesity and type 2 diabetes. So Julia, welcome. And it's your turn if you want to.
Yeah, thank you very much for the kind introduction. I'm gonna share my screen. Can you see it?
Yes.
Okay, thank you. Yes. Okay, so yes, hello everybody, and thank you very much to the EASD for the opportunity to be in Hamburg in the meeting, and also to the ECA community for choosing me to do this Best of EASD. I will be more focused on the diabetes and macrovascular complications beyond. As said by Caterina, there were a number of excellent speakers on this topic in Hamburg, and I enjoy all of them, or a lot of them, but I will only share a tiny selection of my top highlights. First, Matthias Bluer from Germany. He delivered a brilliant presentation on the topic of metabolic healthy obesity. And he commented that while it is well established that weight loss improves metabolic comorbidities and increases survival, until August this year, there was no direct evidence on the effect of weight loss in cardiovascular endpoints. But fortunately, this has been changed with the top-line results for the SELECT study. Here, they indicate that semaglutide in patients with obesity, but not metabolic diseases, which achieve around 16% of average weight loss, resulting in a remarkable 20% reduction in major adverse cardiovascular events. Then he also presented this study from a very large registry of individuals classified according to their BMI and the presence or not of metabolic abnormalities. This figure displayed the risk of myocardial infarction, but similar trends can be observed for those for other cardiometabolic diseases. Yes, basically what I was saying in this slide, or the conclusion of this, the whole presentation from Matthias Bluewer, that it's appeared that individuals with metabolic healthy obesity face an increased risk for developing cardiovascular complications, and if you lose weight, this risk diminishes. So therefore, they may benefit from early treatment and weight reduction. So that was the first study. And then in line with this notion, EASD from China presented her study performed in almost 7,000 type 2 diabetes patients. In this study, they assessed the 10-year atherosclerotic cardiovascular disease risk in these individuals and separated them into 6 groups based on BMI in normal weight, overweight, and obese, and the presence of visceral obesity, if they have or not visceral obesity. So as you can see here, maybe you can see my pointer, it was evident that type 2 diabetes patients with normal weight but visceral obesity had a higher risk than those that were overweight and obese, but had normal, they didn't have visceral obesity. In fact, the visceral fat area was more suggestive of the atherosclerosis risk than BMI, with a threshold of 90 centimeters square as a threshold for a risk of atherosclerosis, and therefore, this patient should initiate management for the primary prevention of atherosclerosis. Next, Amy Mons from USA reviewed insightful findings on adverse vascular outcomes in youth onset of type 1 and type 2 diabetes. Using data from the SEARCH study, she showed concerning trend, the incidence of type 2 diabetes, but also for type 1 diabetes in youth people has increased in the last years, as you can see here. Looking at the incidence of complications in youth with type 2 diabetes, in this case, data from the Today study painted a troubled picture also. These figures reveal alarming high rates of hypertension, kidney disease, dyslipidemia, nerve diseases, and microvascular diseases in this population. And to put just an example, about 80% of youth with type 2 diabetes ever had or have had microvascular complications. However, the gravity of the situation does not end there. This complication often occur in the same subjects. So about 50% of type 2 diabetes youth who had one complication will actually have 2 complications in the future, and 12% will have 3. And you can see this, the onset is quite rapid. It's frequently within the 2 first years. Then talking about jobs, another line of investigation that really caught my attention was this one from Carl Street, also from the USA. His presentation was focused on the epidemiological trend in diabetes and risk factors among the LGBTQ population. His research uncovers significant increases in various diabetes risk factors, such as obesity and the lack of physical activity in non-heterosexual US high school students. And also these disparities, there are extended to the prevalence of diabetes in adults within the LGBTQ community. Moreover, his team published a comprehensive review, which I highly recommend, where the predominant theory to explain this phenomenon is described. This is the minority stress theory, which suggests that in addition to general life stressor, the LGBTQ individuals are exposed to unique multi-level minority stressors that might contribute to cardiovascular health problems. Then in this second part of my talk, I focus more deep into the mechanisms in this study that were about the mechanisms underlying cardiovascular complications in diabetes. First, Vivek Das from Denmark shared his work in which he applied multiomics to identify novel molecular mechanisms of atherosclerotic plaque instability in type 2 diabetes patients. So his investigation was founded on the utilization of biobank materials obtained from both asymptomatic and non-asymptomatic patients, leading to a profound molecular profiling. So this involved gathering RNA-seq data from the plaque themselves, as well as RNA-seq, proteomics, and metabolomics of the local plots surrounding the plaques. Additionally, they conduct GWAS analysis along with further RNA-seq, proteomics, and metabolomics in the peripheral blood. All these data were integrated in the innovative multiomics analytical framework, and some of the notable findings from this research are indicated here. They are currently in the process of validating a set of potential candidate targets of interest. So I eagerly anticipate further developments in this exciting area of research. Then, from Italy, Giuseppina Grieco aimed to unravel the role of specific circulating microRNAs in inflammatory and compensatory mechanisms typical of cardiovascular diseases in type 2 diabetes. And to accomplish this, they recruited type 2 diabetes patients with or without cardiovascular disease. They isolated the plasma samples to measure the circulating pro-inflammatory cytokines for one side, and for the other side, they conduct small RNA sequencing. So through this approach, they pinpointed specific microRNAs that were distinctive to those individuals, type 2 diabetes, with cardiometabolic diseases. And interestingly, these microRNAs were involved in the hypo signaling pathway and correlated with the levels of various plasmatic parameters. Then coming back to China, Longjia Tang and her collaborators embarked on a quest to characterize the epitranscriptome of M6A RNA methylation in human artery endothelial cells that were treated with AGEs. So their studies unveiled a significant alteration in the expression of M6A regulators and M6A landscape in these cells. These results bring to light a novel mechanism of translation regulation independent of transcription. And then combining the RIP-seq and the RNA-seq analysis allows them to identify 7 mRNAs, which might pave the way for the development of future intervention strategies in the context of diabetic vasculopathy. Then finally, I would like to highlight Alessandro Mengozzi from Switzerland, who was one of the recipients of this year's Rising Star Award. In his elegant presentation, he explained his remarkable journey in the field of cardiometabolic epigenetics. Using as a sample some of his unpublished or already published study, he arrived at the conclusion that cardiometabolic diseases are characterized by early and persistent epigenetic cues, that the integration of this epigenetic information is crucial and informs on a very early stage of the disease. Today, targeting epigenetics through non-pharmacological interventions allows to mitigate the residual cardiometabolic damage, but the final aim is in the future that epi drugs are the challenge to effectively oppose cardiometabolic pandemics. With this, I hope I have piqued your curiosity. It's a lot of information in very short time, but maybe I left you here to know more. So I'm looking forward to reuniting all of you in the EASD 2024 in Madrid for more interesting findings. So yes, and thank you very much for your attention.
Thank you very much, Julia, for this nice presentation. Very clear. And now is time for questions. If someone wants to ask something, please, you can intervene or let us the question in the chat. I want to start with the, I was surprised about the study of sexual orientation and diabetes. And I was wondering if the risk is of diabetes is related to type 2 diabetes, type 1 diabetes, or both? do you know if the authors distinguish about the types, or is in a general mood?
Yes, I think it's a very, very interesting field that is now coming up. And there was a lot of discussion at the end also, because it's something that we rarely know of. I wasn't aware of that until I saw the presentation, actually. But all the information I have done from them is already published. So you can, of course, check it out there. But as far as I know, they talk about diabetes in general. They don't so classify between type 1 and type 2 diabetes, as far as I know. Yeah.
And regarding the second study about the overweight, I was wondering if the authors make differences between men and women, or is also a general study of general population.
You mean the study with the visceral obesity?
Yeah.
I think, I'm not sure neither. Again, this study was published also very recently. I think they have both women and men in the cohort, but I'm not sure if they have performed the analysis separating by sex. But it will be nice to see that one. That's very true. With this high number of people, at least it can be conclusive information.
So we have here, I think, one question in the chat from Rana Ansari, and she's sorry, because I lost the. Is there any ethical variation in case of visceral obesity?
Ethnicity. In that study in particular, it was performed in China. So I'm not aware of similar studies performed elsewhere, but I do believe ethnicity has an impact on the metabolic health. In fact, it was also another point highlighted by some of the speakers in that in the same session as Matthias, Mikkel Viden, and so on, that ethnicity it does play a huge role on the biology of adipose tissue and the plasticity to let's say that a different ethnicity can have different responses of the overnutrition, and in that case, a different response of the metabolic health.
Thank you, Julia. It's not, I think it's not more questions, so we're gonna move to the next speaker. Thank you so much for your participation.
Moving now to our third speaker of the day, Carolina Brito Lobato. Carolina is a PhD student at the University of Copenhagen. Her PhD research focuses on finding a treatment for hypoglycemia following gastric bypass surgeries. Today, Carolina will talk about non-insulin-based diabetes therapies. Carolina, thank you for being with us, and the stage is yours.
Thank you. It's my pleasure to join you all. Can you see my slides?
Yes, we can.
Great. So thank you. Good afternoon, everyone. My name is Carolina. I'm coming from Denmark. It was my first time attending EASD, and it was a wonderful week. Everybody was so excited about all the news, and I will try to share some of them with you. From Hamburg, I brought back many ideas, and also Corona. I was probably not the only one, so I did not have as much time as I wished to prepare my slides, but I mean, it was so exciting that I'm sure I have something useful to tell you. So, I couldn't resist to talk a bit as well about the news on obesity, and that's also where I'm starting. So, first of all, the room was completely crowded to hear the results of SURMOUNT-4. And I will briefly touch upon what I think is the highlight for me of this session. So basically, SURMOUNT-4 compared, looked at 783 adults with obesity without diabetes. And they were all treated with tirzepatide, 10 milligrams or 15 milligrams for 36 weeks. The tirzepatide is a dual agonist from Lilly for both GLP-1 and GIP. And after these 36 weeks of treatment with this dual agonist, the patients were either randomized to placebo or to tirzepatide for an additional year. And there were two striking observations. One of them was that tirzepatide actually leads to a 20.9% on average weight loss after these 36 weeks in this population. And a bit even more surprising for me was that the weight loss was sustained after 1 year, more or less in both groups. So even the patients that continued the treatment with placebo, so interrupted tirzepatide treatment, sustained an almost 10% weight loss after 1 year, which we know is a significantly big timeline. So this is, of course, a relevant finding. And yeah, if you sustain the treatment, then you achieve 26% weight loss, which is comparable to bariatric surgery. So we are getting there. But a question that was raised in the discussion and also throughout the conference is if this effect that we are observing with tirzepatide here is a dose response effect, and if we are overestimating or underestimating the other drugs because of different drugs and different doses. And on that regard, I would also like to highlight a meta-analysis presented by Professor Karagiannis from Greece. And he compared 22 trials that compared semaglutide and tirzepatide, each of them on 3 different doses. So tirzepatide, the dual agonist that we just talked about, both GLP-1, GIP agonist, and semaglutide, a long-acting GLP-1 agonist from Novo Nordisk. And each trial included had to have at least 12 years of intervention to be considered in this meta-analysis. And the results are, I would say, striking, that the higher the dose, the greater the efficiency for both tirzepatide and semaglutide. So actually, tirzepatide comes out as superior to semaglutide, especially at the higher doses. But could this be a dose response effect? And it was also mentioned that semaglutide is now starting trials on 8 milligrams and 16 milligrams. So we could be seeing this picture further change in the future. So this was something that I wanted to highlight. Then, of course, there are other analogs on the pipeline. One of the arguments for tirzepatide super effect was that tirzepatide actually is not only a dual agonist of GIP and GLP-1, so it binds to both receptors of GLP-1, GIP and GLP-1. But when we look at the recruitment of GTPs and beta-arrestin recruitment, you see that actually tirzepatide acts as a biased agonist towards the GLP-1 receptor, which further potentially explains its potential to stimulate insulin secretion and the great effects observed with tirzepatide. So yeah, there was, I think, 2-3 sessions where tirzepatide was actually discussed as a super GLP-1 agonist, which is great because it works and we are seeing the clinical results of that. Then another agonists are on the pipeline. We heard about CT868, that when doing an acute study in 20 participants with type 2 diabetes, they did 3 single administration study visits, either with CT868, liraglutide, or placebo. And it was observed that this agonist actually lowered insulin excretion, but also lowered glucose excretion, so improved insulin sensitivity and lowered appetite and hunger scores. And I could go on and on and on, but I won't for the sake of time. There were also other agonists mentioned, triple agonists, dual agonists, a lot of analogs on the pipeline to come up. And lastly, I would like to mention also what was told about bariatric surgery. So it confirms its efficiency and its role in obesity and diabetes treatment. I will highlight two studies. The Oseberg randomized clinical trial results were presented by Dr. Haug. And basically in this trial, they randomized patients to either have gastric bypass or sleeve and followed them up for a period of 5 years. To be eligible, they had to have obesity grade 2 or type 2 diabetes. And the remission rates were significantly higher for gastric bypass at 5 years, with also a higher weight loss. And notice here that they document an average weight loss of 22%, and this is absolutely comparable to what we saw before with the agonists. So we are getting there. And lastly, we also heard about the 30 years results on the SOS study from Professor Sjöholm. And she told us that when you they considered 586 patients with type 2 diabetes that were followed for at least 2 years. More or less half of them submitted to bariatric surgery and the other half to the traditional obesity care. We saw that diabetes remission achieved with either treatment actually decreased mortality by 41% and further increased life expectancy for 4.1 years. So there is definitely a role for diabetes remission on our focus in the years to come. So as take-home messages, I will finally just leave you with this last message that achieving diabetes remission is of great clinical relevance and something that we should be aiming for. Diabetes and obesity treatments are changing, and I believe at an unprecedented rate. We are seeing data popping up every day. I mean, this meeting was so exciting because of that. We are really revolutionizing treatment for these patients. There are multiple incretin agonists under investigation and showing great promise. And yes, bariatric surgery is still an option of great efficiency in the long term. And yeah, I share the idea that we need to see each other next year at EASD. Thank you.
Thank you, Carolina, for this very interesting presentation. Indeed, very interesting studies you covered in there. If I may start with a question. So you mentioned that the higher doses of some agonists were more efficient in terms of reducing the body weight, right?
Mm-hmm.
Were this associated with more side effects compared to the lower doses, which might limit the use of higher doses in this case?
Mm-hmm. That was a popular concern throughout the discussion. And all studies back them up, saying that the rate of side effects was not increased in comparison to the other agonists included in the trials. So the picture is that I believe every person, of course, will have a different dose they can tolerate, a maximal dose, and depending on that, each agonist will have a side effects profile. But that wasn't the main concern that was documented by the researchers, no.
And do you see any potential of using these agonists in treating type 1 diabetes? Were there any discussions in this regard, given their efficiency in decreasing blood glucose and hemoglobin A1C?
I'm not aware of discussions taking place there. Of course, if you consider that they also seem to reduce inflammation, then definitely that might be a role for that, but I'm not aware of any study that touched upon that on EASD.
Yeah, I think it'll be a tricky one. Yeah, I don't think we have any other questions in the chat. And in this case, we can move up to our fourth speaker. Yeah.
Thank you.
Okay, so our last speaker, our last woman in science here today is Samantha Morón Ros from Spain. She completed her PhD at the University of Barcelona, where she studied different growth factors in the crosstalk between different tissues in the context of thermogenesis and obesity. And nowadays is a postdoctoral researcher at EDPAS in Barcelona. So welcome, Samantha, and the turn is yours.
Thank you for this kind introduction. Let me share the screen. One moment. Can you see it?
Yes, we can see.
Okay, so hello everyone. Thanks for the introduction. And my name is Samantha Morón Ros. And today I'm going to present you some of the highlights I found deeply interesting about the EASD annual meeting, which took place in Hamburg last month. And I would like to thank the organization committee for asking me to do this talk. So the topics I am going to focus and I'm going to speak about are diabetes genetics, biomarkers, and epidemiology. In 10 minutes, it's impossible to talk of all of the amazing work which has been done all around the globe. So I selected some oral presentations that I think you are going to find interesting also. And I tell you, if you have access to the virtual meeting and you can have access to the program, I encourage you to look in the program and look at the sessions you are most interested, because this year was really amazing. All the presentations and all the work that has been done. So as we all know, there are different types of diabetes mellitus, which is in three general groups: the type 1, the type 2, or the gestational diabetes, but they are more related to monogenic genetic implications like LADA or MODY. But I would like to mark that diabetes genetics and epidemiology are different depending on the disease we are talking about. So that's a thing we have to take into account. So in all the talks that I have found in this year that I find interesting, they focus a lot in the importance of the early detection of these different kinds of diabetes. And they put the focus in the screening of the population and also in the finding of novel biomarkers to detect the diabetes. So first of all, I am going to focus on diabetic biomarkers. And I'm going to focus in one session, in one talk from the EASD Academy Symposium with the title "From Stem Cells to Islets: Starting an Independent Career in Diabetes Research," performed by Dr. Balboa. Dr. Balboa explained in this talk his last years as a researcher and his future on his new group. But I am focused, and today I'm going to focus in a tool he's been using to study the formation of beta cells. He focused in human-induced pluripotent stem cells, and the creation of these pluripotent stem cells from somatic cells have opened a window of possible applications, both from the study of basic research for the study of diabetes and for the treatment of the disease. In his paper, he explained a protocol how he formed functional stem cell derived islets for the study of genetic maturation of beta cells and pancreatic islets. I encourage you to see the talk on the paper because with this kind of islet formation from stem cells, he's able to study the differentiation of the beta cells and all the differentiation of different kind of cells that form the pancreatic islets, and study in each step of the way some diabetic markers responsible of for example, type 1 diabetes or the higher risk to have another types of diabetes. In fact, these islets that he made from stem cells are functional. So I think this is such an amazing tool for the study of diabetes in basic research, but also for the future for possible islet transplantation. Now I'm going to focus on epidemiological and biomarkers talks. And for that, I selected some oral presentations I hope you enjoy. First of all, I'm going to focus in the oral presentation 3, titled Pregnancy and Diabetes, Lessons from Cohort Studies. And now I am going to focus on the 15th oral presentation, which is titled A Genetic Screening of Gestational Diabetes in Early Pregnancy, Bioral Glucose, Tolerance Tests and Biomarkers, a multi-center cohort study by Dr. Han. Gestational diabetes mellitus is defined as glucose intolerance that starts or is recognized during pregnancy, usually in the second or the third trimester. How was it detected in these centers, in this multi-center cohort study before this study? They were searching for pre-existing diabetes mellitus in mothers or screening the gestational diabetes mellitus, but at week 24. But the identification of mothers at high risk of developing diabetes mellitus, gestational diabetes mellitus in this case, would be beneficial to improve the pregnancy. So, in this clinical study, they performed an OGTT, but not at the week 24. They go earlier in the pregnancy, and they started testing the moms, the pregnant people at 12 or 15 weeks. And they look for different biomarkers, such as glucose and some lipids, to detect early GDM or the risk of a person to have GDM. And it's important, this study, because they say that the fasting glucose with the OGTT, as well as biochemical parameters such as TGA, insulin, or adiponectin, are significantly associated with later progression of the GDM or the need of glucose lowering medication. So this change in the rules of the detection of gestational diabetes mellitus could be useful to identify high-risk mothers before they develop gestational diabetes mellitus. In the same oral presentation, there was another talk by Dr. Farrelly called Implementation of a Screening Protocol for the Detection of Maturity Onset Diabetes of the Young, MODI, in Pregnancy, a retrospective preliminary analysis. We know that MODI is a monogenic autosomal dominant condition, and the clinical criteria for diagnosis is a diabetic onset before 25 years old of age in a single family member, the presence of diabetes in 2 generations consecutively, the sustained endogenous insulin secretion of and the absence of beta cell antibodies. But there was no criteria of diagnosis within pregnancy. In this case, they made the retrospective preliminary analysis focusing on the MODI affected with the GCK. And this MODI can be misdiagnosed as gestational diabetes mellitus. They say that maternal and fetal MODY phenotype has more impact on the fetal outcomes than the treatment of maternal hyperglycemia. And they see that the misdiagnosis of this MODY, diabetes mellitus, with gestational diabetes mellitus can bring problems both in the fetus and in the delivery of the fetus at the end of the pregnancy. So they try to make a screening protocol in pregnant people who has developed glucose intolerance during pregnancy. And they focus on different factors such as the BMI or the fasting glucose to determine if this person who has developed glucose intolerance can have or can be tested, genetic tested for MODY. And the conclusion of this study is that this implementation of a screening protocol for the detection of MODY is appropriate. However, they talk about how they have to really well perform this screening protocol to not miss positive MODYs because of different because of higher BMI or because of different adverse results in fasting glucose. In another oral presentation called Diet and Exposome, in the presentation 21, called The Associations Between Metabolomic Response to a Liquid Meal, Mixed Meal, and Increased Incidence of Type 2 Diabetes, Are There Novel Biomarkers Beyond Glucose and Triglyceride Response? By Dr. Ligao, I found it really interesting. Individuals who will ultimately develop type 2 diabetes reveal different metabolic profiles, but not in the moment the diseases develop or manifest. They have these different metabolic profiles years before. These studies have, all the studies or most of the studies have focused in finding biomarkers in fasting conditions. But due to the nature of this disease, the patients frequently are in postprandial state, not in fasting conditions. So they think about how about if we change this protocol, this criteria, and instead of searching the biomarkers in fasting state, we move and search for biomarkers in postprandial state. So what they did in this study was to take a blood sample after an overnight fasting of the patients. Then, 5 minutes after, they gave the patients a liquid mixed meal, a controlled liquid mixed meal, and they waited until they reached a postprandial stage, which they took another blood sample. And they compare by NMR the metabolomics that were in the blood sample in postprandial state and the blood sample in fasting state. As you can see in the right, there's a lot of metabolites that are in both conditions, but there are some that differ from fasting to postprandial. The result is that in this study they found 25 metabolites that are associated only with postprandial state. So the conclusion of this study is that even glucose remains as the strongest biomarker of type 2 diabetes incident in the cohort they were studying. There is a very important conclusion here, that the postprandial metabolism is different than fasting metabolism. So there is a useful way to detect type 2 diabetes by novel metabolites changing from fasting conditions to postprandial conditions. And finally, I would like to talk about the talk of Dr. Emily Sims, which she talked about the importance of universal screening. In her talk, Universal Screening, Is It Around the Corner? She focused a lot on that there it's true that there are some patients of type 1 diabetes that has a family with the same disease, but there's a lot of people, a lot of patients of type 1 diabetes that they were the first in the family that has this disease. So the importance of making a screening and maybe in early stages of life or a little after would be a good way to identify the possible future patients of type 1 diabetes before they have what we call the beta cell decline, before the start of the disease. And even in this talk was very interesting because one doctor from the audience, which she was from Italy, she said that even in Italy, they started this fall to make a law to start these screenings in the young people. So I think it's very important. And as I saw in all these talks about epidemiology and novel biomarkers, and as I said before, they focus a lot on the early screening of these diseases. It's of course we have to take into account that this is money, this is not cheap, but I think that an early detection of the disease would save a lot of pain from the patients and a lot of money in the governments, in the health insurance, and etc. So thanks for your attention, and I would gladly take questions from now on.
Thank you so much, Samantha, for your nice presentation, very clear, your summary. And now we are open for discussion and questions. If you have questions, please let us at the chat or intervene. So I have one question regarding the pregnancy study. I was wondering what the authors attach most important to. So, I mean, the OGTT is more important than the plasma values biomarker, or is the plasma markers or all together?
I think they focus more on the OGTT, on the fasting glucose and the response in the response of the insulin in the OGTT, because fasting glucose and these levels of glucose in all the OGTT, it's one of the main criteria of detecting gestational diabetes mellitus. But I think that they are moving like trying to find some biomarkers, because maybe you are not having like an intolerance of glucose yet, but you can try to find some markers to keep you on the alert, to keep you like, okay, this mother maybe is in high risk to have gestational diabetes mellitus. And for example, in the MODI case, they focus a lot in not mismatch and not misdiagnose gestational diabetes mellitus when it's MODI, because in this case, if they show, for example, a table that if the mother is MODI positive and in the fetus is MODI positive, there were not a lot of consequences for the fetus. But if the mother is MODI positive and is misdiagnosed as gestational diabetes mellitus, and the fetus is not MODI positive, the fetus can have some problems in the formation and some problems in the delivery. So I think that the more markers and the more tests we have to determine better which kind of disease you have, the better. And it's for the treatment of these pregnant people. I don't know if I answered correctly the.
Yeah, and finally, I would like to know your opinion about what is the most relevant thing in your topic. I mean, if you have to choose one study of this big topic, which one do you choose?
Well, I have selected some that I found like more diverse to have like all types of diabetes. But I think that, as I said, that the timing of screening is really important, depending on the type of diabetes you are looking for. And they focused a lot of early detection of diabetes is beneficial, but depending on the diabetes you are looking for. For example, if you are trying to find like what diabetes you are going to go to the children, but maybe you are missing some children that are going to be diabetes type 1 years later. So I think that the most important thing is the timing of the screening.
Thank you. I think that there is no more questions in the chat. Only a reminder that all of you have the presentation recording of the annual meeting at the EASD now is closed only for the registered people, but from 4th of November, it will be available in EASD Media Center. So thank you so much, Samantha, and all of the speakers. And now Rula is going to close the session.
Thank you, Bia, and thank you all for being with us today. We just would like to take this opportunity to remind everyone that EASD Early Career Academy is now accepting applications for new committee members until the 17th of November. So please apply so you can join us and have fun. We would also like to remind you that we have a webinar on the 23rd of November, where we'll be privileged to host Julene Zirath, who will be talking to us about grant writing. We hope to see you all there, and thank you.